Go ahead.
Hello, everyone. Welcome to another of our educational presentations from the CCPC, our pain center. We do a variety of things, including e-consults for pain and also educational presentations on various topics. So today's presentation is on substance use disorders, but it is framed in the context of identifying, treating, and referring out patients with substance use disorders and substance misuse in the context of chronic pain management. I'm Dr. Surita Rao. I'm an associate professor of psychiatry at the University of Connecticut School of Medicine. I'm an addiction psychiatrist, so I'm subspecialized in addictions. I have to tell you guys that I have a lot of slides today, but I will not linger over the statistics slides. We all know that there is a opioid epidemic, and I think we have seen enough statistics in other presentations to get some underpinnings about the statistics. So let me just dive right into it. So these are the objectives. We hope that you will improve your knowledge base in substance use disorder, particularly in pain patients. Get some more skills and knowledge to identify substance use disorder in pain patients and recognize the appropriateness of in-office treatment versus referral to a specialized treatment program like a residential program or a methadone maintenance program or intensive outpatient program. So this section is on neurobiology, and honestly, if you don't remember anything from my presentation, I would be happy if you just remembered the neurobiology slides. You would need to remember nothing else. So a lot of people still in society today, including some healthcare professionals, still believe that addiction is kind of bad behavior or social illness. It has a lot of social implications, but it is one of the most hardwired brain disorders that there is. In some ways, addictions is even more hardwired than schizophrenia, but it carries so much stigma that people don't look at it the same way. So the neurobiology slides just remind us, clinicians, that we're dealing with something that's a disease in the brain. So the mesolimbic pathway, which is a very ancient pathway in our brain from an evolutionary perspective, it is the reward and reinforcement pathway of the brain. What does that mean? It means that it mediates drive behaviors like food and sex. So if the organism doesn't eat, it will die out. And if it doesn't mate and have baby animals, then the species will die out. So in a substance use disorder, when the brain develops addiction, then this mesolimbic dopaminergic pathway is hijacked by the addictive illness to make the brain think that the drug is more important than survival and survival of the next generation. So it's almost, sometimes I will explain to my patients that it's almost like a bit of a possession. It's not a possession, obviously, but it's almost like they can envision the addictive disease as a small monster type creature that lives in their brain. And if they feed it, then it will become huge and basically take over their brain and their life. But if they starve it and lock it in a cage and they hold the key, then it becomes small and powerless. But if they give it even one crust of bread, it will immediately become much larger and come out. Because the reason for this like cutesy analogy is that you cannot get cured once you have an addictive illness. Your brain cannot go back to being a non-addicted brain, but you can go into recovery the same as you would for cancer. Um, so this is a dopaminergic pathway. It's one of the dopaminergic pathways of the brain. And when somebody uses opiates or cocaine or smokes a cigarette, then our brain is flooded with a lot of dopamine, which is symbolically, it's not an exact thing, but symbolically, it's a million more molecules than what we would get if we studied very hard for an exam and did really well. Or let's say my presentation went well and I've worked hard for it. So let's say I get like symbolically 10 molecules of dopamine flooding my brain and I feel rewarded and happy. But if I were to now, use some heroin, I would have like 5,000 uh, dopamine molecules flooding my brain. So the effect is much larger. For doctors specializing in either addiction medicine or addiction psychiatry, the process addictions, food and sex, are quite fascinating for us because we're not even introducing something like a drug or a behavior like gambling into the brain. The brain takes its own drive processes and makes them addictive. So this is very important for us as clinicians to know because sometimes as doctors, as nurses, physician's assistants, nurse practitioners, whatever we do, we sometimes feel that if we electronically prescribe something or write it on a prescription pad, as we used to do when I was younger, that it's somehow safer than an illegal drug. Maybe it's safer in the sense that we know what's in it, but to the brain, it doesn't know the difference between a legal drug, illegal drug, prescribed drug, or drug, quote unquote, bought on the street. But we all know that the current opioid epidemic did not start out with street drugs, but of course now the primary drug is fentanyl, illicit, in large quantities. And another thing that's very important to tell our patients when they're asking you, is there something else that can take care of my pain? If there's something else that can take care of my pain, then I'm ready to give up the opiates. It's very important to say to them in a calm manner that there's nothing in science or nature that can recreate the effects of addictive substances on the brain, whether it's prescribed or not. And that's why they're so addictive. So for me as a psychiatrist, people will say, oh, I'll give up my Xanax or my clonazepam if I can get something else that manages my anxiety the same way. And it's important for me to tell them that there is nothing else, but we'll do other things to help them. So there are a lot of definitions for substance use disorders. One of the big challenges in the opioid epidemic, in trying to identify a substance use disorder in the context of chronic pain management, particularly the patient who gets prescribed opioids for chronic pain, is that a lot of the diagnostic criteria, like DSM-5, which psychiatrists use, ICD-10, they don't really describe the behaviors that the patients who get all their opioids from one doctor, one nurse practitioner, and fill it at one pharmacy, like what they don't meet some of those criteria, but we know sometimes like what is going on. So another way to think about it, which is a very um, sort of clear way to think about addictions, is use despite consequences. So those consequences could be social, they could be health, which could be psychiatric or other physical symptoms. They could be family and relationships, career and work responsibilities. They could be legal issues. You could get a DUI for driving while under the influence of a prescribed substance if you drove badly enough. So this is the American Society of Addiction Medicine's short definition of addiction. I've just thrown the slide in. If anybody wants it, we'll send it to you. But in the interest of time, I'm going to skip this. I'm just going to say that if you look at the second paragraph, it's characterized by inability to consistently abstain. So sometimes people who have substance use disorders will stop for 3 months and say, look, I'm fine. But the problem is that they go back. So, but it's not their fault per se. Their brain has changed. So like other chronic diseases, like cardiac disease, addiction often involves cycles of relapse and remission. But if somebody was hospitalized with a heart attack, even if they had been, eating a lot of fast foods or not exercising, we wouldn't be as angry with them sometimes as some healthcare professionals are when people come in having relapsed yet again. So the other thing to remember about the neurobiology, if you go back to the mesolimbic pathway, is that each drug of abuse, there's no drug of abuse that does not have endogenous receptors. So opioids, we're going to focus this talk on opioids, has their endogenous opioid receptors, of which the mu opioid receptor, which mediates pain and euphoria, is the most important one for people becoming, misusing opioids or becoming dependent on them or developing an opioid use disorder. But every drug of abuse has secondary effects on the dopaminergic pathway, and that's what makes the person go back. So For the opioids, if you take the mu opioid receptors, their important part is the euphoria, the physical dependence, even to some extent, all of the attachment. But nobody would ever go back after detox if we didn't have these secondary effects on the dopaminergic pathway. So we already went over this. We'll just linger over it for like 15 seconds. So just remember, every drug of abuse, including alcohol, alcohol is a drug, has its endogenous receptors. Why we're made this way, I don't know. But that's not the reason why people go back. People go back because of euphoric recall. They remember the amazing feeling, but they don't remember the difficult parts that followed. So for me, I know that I would never develop, but I don't think I would develop a substance use disorder. But if I had a substance, it would be food. And if I had to identify the two foods, the one would be rice because I'm from India and it's kind of wired into my brain. And the other would be fried chicken, which I discovered after moving to the United States. So I only eat fried chicken like once or twice a year, but I could just remember the taste and want to drive to a KFC. So the opioid system, there's more and more research coming out about the opioid system. One thing to remember is that there has been an incredible amount of basic science research funded by the federal government going back like 25 years in the field of substance use disorders. And there's been a lot of amazing research going back 25 years. Sadly, it has not translated into any dramatic clinical treatments, like some one thing that can make somebody better. But we do have a lot of good treatments if people were to utilize them, which requires motivation, which sometimes is a bit of a intangible thing. So the opioid system in our bodies is highly complex. It's a far-reaching system. And if you go back to the mesolimbic pathway, a variety of animals have the mesolimbic pathway. So in many ways, you can consider it the lizard brain because it is phylogenetically old. As we evolved from lower animals, and by lower, I don't mean in a speciesist kind of way, but animals that had a simpler brain, like the lizard, this mesolimbic pathway came with us because it mediates drive behaviors. But if you go to just the opioid system, just the opioid receptors, which is a different set of receptors, they were already established in a common ancestor over 450 million years ago. So when you are writing that prescription or putting it in electronically for a patient for any kind of opioid, just remember, this is not modern medicine you're dealing with. You're dealing with receptors that were established in some animals that are probably already extinct 450 million years ago. And we have to respect Mother Nature in that way. So the opioid system appears in its modern form in all jawed vertebrates. So jawed vertebrates, we are tailless primates and we're also jawed vertebrates. And they have a huge expression in the brain. I won't read out all these different areas, but they also have an expression in the spinal cord and peripheral neurons. And we all know that pain pathways go both ways, right? So there can be a lot of sort of talk between the brain, the spinal cord, and the peripheral neurons. So because of this complicated endogenous opioid system, when you're sitting with that patient with chronic pain in your office, remember that the endogenous opioid receptors, they interface with a variety of other neurotransmitter systems. That's why naltrexone is a medication that's used for treatment of alcohol use disorder, but it is a mu opioid antagonist because there are connections between the mu opioid system and GABA in the brain. So the opioid system interfaces with endocannabinoid system, serotonergic system, oxytocin, vasopressin, and very importantly, the glucocorticoid axis. And the glucocorticoid axis is very implicated in depression. So it's a regulator of emotional circuitry in the brain, and it's responsible for a moment-to-moment like fine-tuning of our affective state, like how we feel in terms of mood, anxiety, and our emotional response to positive and negative experiences. It's important to remember that we evolved this way. So And this regulation is constantly being refined by second messengers, changes in peptide tones. There's a lot of stuff happening in our brain all the time in response to our life circumstances. And what this results in is a bi-directional relationship between opioid use disorder and depression, and pain is often a mediating factor in this relationship. So you can't really separate out. It's like a chicken and egg thing, but then there's a third thing in the chicken and egg. So there's opioid use disorder, there's a certain amount of dysphoria, it may not be a clinical depression, and then there is like pain, and each of them is interconnected with the other. And in the human clinical population, mood disorders, particularly depression, very often they're comorbid with opioid use or opioid misuse. And then, something we sometimes forget, but addiction specialists, we always remember this, is that opioids can induce hyperalgesia. Then that can make somebody feel much worse because they're like, why am I worse? And then it becomes kind of a vicious cycle. So we went through the neurobiology. Now we're just going to skim the history and statistics, like literally skim. But if any of you want the slide deck, we'll send it to you. So opioids are not new drugs. They have always been a part of human civilization. So if you think about where did the first city-based civilizations evolved, Mesopotamia, India, China, and Egypt. I mean, these were pretty sophisticated civilizations of their time. They built, really beautiful structures. They had involved scripts, and I can guarantee you they had opioids. And the Sumerians were one of the early civilizations that documented that they had opioids. And why did they have opioids? Because opioids are amazing pain medication. So if you were somebody in ancient China or India and you needed to amputate somebody's leg, obviously you would have given them some form of opioids because you knew it existed. Alcohol also existed. So, but many of our root crises of the current opioid crisis are sort of uniquely modern. And they began with the isolation of morphine from opium in 1804. So remember I said the neurobiology slides are the only things I wanted you guys to remember. Well, was not fully telling the truth, I guess, because I want you to remember this slide as well. So this opioid epidemic is not the first opioid epidemic in the United States. The United States, we've had like multiple opioid epidemics. Once they are corralled and fixed, we forget them and we kind of are doomed to repeat the same thing. It's like a constant cycle like the Matrix. So this particular opioid epidemic that we're going through now overlaid by the coronavirus, the pandemic, during which time like opioid overdoses have increased quite significantly, which you can imagine for a variety of reasons. This opioid epidemic is very similar to one that happened at the turn of the century, when American physicians began to use morphine and the hypodermic needle widely, and they just began to prescribe morphine for everything. So if your leg was getting amputated, you got morphine. If you were having, bad PMS and menstrual cramps, you got morphine. And so this led to opioid epidemic very similar to our current epidemic. And there were widespread efforts by the federal government at that time. It started at the city and state level and then extended to the federal government, which included two arms, just like today. One was education of physicians, which really worked. And the other one was draconian measures like the Harrison Narcotic Act of 1914. And by 1917, it was being interpreted that some physicians were even jailed for prescribing opiates. Sadly, this knowledge was lost with time and history repeated itself. So I'm just going to skim over the statistics slide because I want to get into the treatment a little bit. So, the media has a really, this is an old slide, but it's very important even today. The media has a certain script for our current opioid epidemic. I have a little bit of a problem with it for two reasons. One, it demonizes physicians a little bit or a lot. And two, it sort of says that, here's a person, they were like a hardworking husband and father, and one day they were standing on a ladder repairing their roof and they fell off. They went to a doctor who prescribed them opioids without really telling them how dangerous they are. And then when they tried to get off, they had withdrawal, and now they were doomed to take them for the rest of their life. Now, if you go back to my neurobiology slides, most people who take opioids get off the opioids. If any of us have taken opioids for anything, I took them when I had my appendix taken out. I took them 21 years ago after my C-section when my son was born. So I didn't keep craving them. And that's not because I'm some kind of saintly person with tremendous willpower. It's because they don't do the same thing in my brain as the brain of somebody who's vulnerable to a substance use disorder. So if you look into the history of people who have become very psychologically attached or have begun to misuse or even develop a full-fledged opioid use disorder from their prescribed opioids, they have family history of some kind of addiction, and they often were using alcohol or marijuana quite significantly, even if they didn't identify it as a use disorder, maybe in their high school or college years. So people who are addicted to alcohol are twice as likely to be addicted to heroin, marijuana 3 times, cocaine 15 times, opioid painkillers, obviously they already have an opioid use disorder. Remember, heroin was once a pharmaceutical developed by Bayer Pharmaceuticals. So I won't linger over the statistics because then I won't be able to get through the rest of the talk. And so I'm just going to show you some emergency room visits. This is by study funded by the federal government, which is done repeatedly every few years by SAMHSA, Substance Abuse and Mental Health Administration. If you go into their website, you can go down a rabbit hole of statistics. So you can see that this is the emergency room visits involving heroin and non-medical use of prescription opioids. And they are some of the top substances in this sample of hospitals. So 18% of substance use related ED visits, not all ED visits, involved heroin, and 16% involved the non-medical use of prescription opioids. The rest of the country has been going also through a methamphetamine epidemic for many years, but thankfully in New England, we have been spared that, but it is now becoming more popular here. Hopefully it will not take off the way it did in the rest of the country. So we all know this, relentlessly, the opioid overdose deaths have climbed. There has been opioid overdose deaths happening during the coronavirus pandemic, and they have cost almost 70,000 lives in 2020 alone. And 841,000, approximately, this many people have died since 1999. And they don't, if you look at the coroner's data, they often have other things, cocaine, psychostimulants, alcohol, benzodiazepines. So your patients may not tell you this, but they're using other things. Not every one of them, but some. All right, I'm going to jump over the rest of the statistics, except to tell you that now there are these racial disparities that are emerging. So one of the issues that has happened in this current opioid epidemic, which is very similar to the one at the turn of the century, is that it was not an epidemic in the inner city of African Americans or, socioeconomically depressed populations. This was an epidemic that occurred primarily in rural America or in middle class America, and the majority of people who were affected by this opioid epidemic were white, and a lot of them were middle-aged women. So, but now the opioid overdose death among African Americans has increased by 38%. And a reason for that is that's conjectured is that somehow all the efforts by the federal government are not either reaching African American people or are not having the prevention and treatment efforts not having the same effect. So that's something that's troubling and something to look at. So while it's primarily middle-aged people, young women are also have been getting dependent on opioids, developing opioid use disorders for quite a while now, and they could get pregnant at any time. So we have a big increase. And this data is old, but it hasn't changed that much. It's 5-fold increase from 2000 to 2009, and it's sort of remained a major problem. Babies who are born to mothers who are, misusing or have become addicted to opioids. gold standard treatment for those mothers is methadone maintenance. If they're already on buprenorphine maintenance, do not switch them over unless they're unable to stay sober. Just maintain them on buprenorphine. Just switch from the buprenorphine naloxone formulation to the pure buprenorphine formulation. And why is that? So that if they were to dissolve your tablet or film and inject it, they will not go into withdrawal, because opioid withdrawal is risky for the baby. It could result in a spontaneous miscarriage, and it could result in a continuous cycle of use and detoxification. So the recommendation is that we do not, under any circumstances, take a pregnant mother who is addicted to opioids and detoxify them. We put them on maintenance treatment, and then if they want to go off after the baby's born, they can. Breastfeeding is safe for mothers on methadone maintenance or buprenorphine maintenance. The babies already received these medications, and so it almost helps them to detox. All right, so now we're going to get into a very challenging section, which is diagnosis of opioid use disorders among patients with chronic pain. So, which is very difficult, as you all know. So as I said early in the presentation, most of our DSM-5 or ICD-10 criteria, they are much more easy to apply to patients who are using opioids that they have obtained in an illicit manner. Even if it's from friends and family, still you could say. But for people who are sitting in your office and are taking a ton of opioids, maybe they're also on a muscle relaxant, maybe they're drinking at home, they're on a benzodiazepine, they're incredibly attached to all these medications. You're sort of getting the strong feeling that they just are using them to function in life, to kind of do life. And the pain and their dysphoria and their life have gotten intertwined. It's very difficult to kind of establish a diagnosis, and because there's a big gray zone also. And it can be kind of hard to talk to patients. But I think now, with so much education by the federal government, you could talk to them about the fact that there's an opioid epidemic, and that we realize that these medications are not really as safe as they appear to be. Another conundrum is that pain is a subjective thing. I mean, if the patient's feeling pain, they're feeling pain, but it cannot be measured objectively, and it is intertwined in the brain and the body with mood, anxiety, other factors. And so if you go back to the opioid receptors, there are receptors in the spinal cord, receptors in the periphery, receptors in the brain, and different receptors don't exist in little silos by themselves in our brain. They talk to each other constantly through neurotransmitters. So there can be problematic opioid use, which is not all the way an opioid use disorder, but it can mean compulsive opioid seeking, and then going all the way into addiction or an opioid use disorder. It arises in some fraction of patients who are treated with opioids for their chronic pain. Everybody know. Let's say you have a patient that comes back every month and has used all their opioids. It doesn't necessarily mean that they have a problem, but another patient who's sort of similar might. So that's the challenge. And I don't have any magic bullet, actually. It's a slow process of talking to your patient. And we already discussed the next bullet. So this is not from any research study. This is from my experience as a clinician. So there is a gray zone. It includes a strong psychological dependence on prescribed opioids, right? People who are using it to treat their mood disorder, their anxiety, their life problems. And for people who are vulnerable, whose brains are vulnerable to either opioid misuse or full-fledged opioid use disorder, opioids don't have the same effect on them as they have on the rest of us. So I have gone to I've sat in on healthcare professionals discussing opioid use disorder, and sometimes they'll just roll their eyes and say, "Oh, I don't know why people just abuse them. I was given opioids for this and it made me nauseous or it made me sleepy." Well, why would you abuse something that made you nauseous or sleepy, right? You're only going to abuse something that gives you a very good effect. So when I talk to my patients who have developed opioid use disorders, whether from a street opioid or prescribed opioid, they feel very energized and calm the first time they take opioids. They will tell you they got their whole day done, they mowed the lawn, and this is whether they have chronic pain or not. So it kind of latches on to their brain, just loves it. overusing prescribed opioids, running out early, and using it by other methods like crushing and snorting, intravenous routes. I mean, these are huge red flags. Selling of the prescribed opioids, that may not mean that they have an opioid use disorder. It just might mean they need the money or they're poor. Supplementing with street bought opioids. You can buy anything on the street. You can buy methadone, you can buy buprenorphine, you can buy, fentanyl, obviously, but you can buy prescribed opioids on the street. You can obtain them from friends and family. So if their drug screen is positive for a particular opioid, they could have supplemented with more. But I always tell my patients, we're not the sobriety police, so we are not here to like catch you doing something, because ultimately it's your life and health, and you have to kind of want to get better. So a little bit about the withdrawal and pharmacotherapy. So opioid withdrawal symptoms are terrible. I mean, they are really, the people feel like they're dying. It's like having the stomach flu and the upper respiratory flu together. Runny nose, tearing from the eyes, chills, muscle aches and pains, terrible abdominal cramps, diarrhea, vomiting, nausea, insomnia, severe anxiety, mood swings, intense cravings. So opioid withdrawal is not life-threatening at all unless you're very sick or elderly, but it can feel like you're dying. So it's important to get people through this in a medically stable manner. And it's important to tell patients that there is no silver bullet, right? And one of the most difficult things to come off of is a combination of opioids and alcohol, or opioids and benzodiazepines. So there's a protracted or post-acute withdrawal that lasts after the acute detoxification period is over. Really, you can detoxify anybody off any opioid in 3 to 5 days. I have in my past treated impaired physicians, impaired pharmacists, healthcare professionals basically, and nurses. The doctors, particularly the anesthesiologists and the pharmacists, had access to opioids like no regular person would ever have. And they were all detoxed within 3 days using buprenorphine, and nothing bad happened to them. So it can be done, but there's a huge, psychological component to people's attachment. But there is a biological post-acute withdrawal that often drives people into relapse. So it consists of insomnia, anxiety, intense cravings, mood shifts, irritability. And some nausea and diarrhea may happen for a few weeks. It's important to treat this when your patient's completely off their opioids to help them. So psychosocial interventions is very important. This is not a disease that can just get better with some, medical arrangement. Because remember, the big part of treatment is psychosocial treatments. After the acute detoxification period is over, I would say that medications form only about 10 to 20% of the treatment. So here are some of the medications that we use in a variety of combinations for post-acute withdrawal. It's gabapentin, trazodone, gabapentin for anxiety, for sleep, for moodiness, irritability, trazodone, doxepin for sleep, clonidine. I sometimes will put a 0.1 milligram clonidine patch on a patient every 7 days for 2 to 3 weeks. Guanfacine for anxiety and irritability. If your patient is really having severe mood swings or very irritable, disorganizing anxiety, you can put them for a short bit of time, 1 to 3 months, on atypical antipsychotic. If you put them on something like quetiapine, everything's going to be like erased temporarily. And supportive therapy, maybe see them more frequently and refer them to treatment, refer them to an intensive outpatient program or Narcotics Anonymous. Some people go to Alcoholics Anonymous, that alcohol's not their main problem because they find longer term sobriety there. Motivation enhancement therapy. So these are the medications that are used for the treatment of opioid use disorders. Out of these medications, you can prescribe naltrexone in the office at any time. Just remember, the patient has to be fully off their opioids. So 7 days from the last dose, otherwise they will go into terrible withdrawal. So the naltrexone is an antagonist at the mu-opioid receptor. It binds very tightly to the mu-opioid receptor and turns it off completely. So it can exacerbate pre-existing dysphoria, and it can cause some dysphoria because even the endogenous opioids are not able to get in. So that's something to remember. And people typically take it for maintenance for opioid use disorder. They typically take it 100 milligrams on Monday and Wednesday, and 150 milligrams on Fridays. Often watched by a family member or a loved one or their AA or NA sponsor, or if in case of a healthcare professional, by identified person at work, because any blocker is not very useful unless somebody's watching you take it so that they know, that you're taking it. For alcohol use disorder, naltrexone can help reduce heavy drinking, can help people come back if they've had a slip. And there it's prescribed 50 milligrams every day, and nobody watches you take it. Then you have the opioid agonists. You have methadone, full agonist, buprenorphine, partial agonist. If you get your XDA number, which is not difficult, now they're saying they're even going to waive that soon. Then you can prescribe buprenorphine in the office. You should refer your patient to some kind of psychosocial treatment, depending on what they need, because it's not just medications. And methadone for opioid use disorder maintenance treatment, it is illegal to prescribe in the office. Any physician can write a 2-day prescription for opioid use disorder. I would advise against never writing it in the emergency room, office, or anywhere else, because your patient could die holding your prescription in their hand. But refer them to a methadone maintenance program where there is a tremendous amount of structure. Some people will say, oh, it's so ball and chain, where it's ball and chain for a reason. It's ball and chain because it helps the patient's brain to learn to have structure, to follow some rules, to see at least the nurse every day and their substance abuse counselor once a week, go to groups, get drug screens. So it kind of helps their brain to come back. And at higher doses, very important to know, methadone and buprenorphine act as quote unquote blockers. So they're not real blockers like naltrexone, but they occupy all the receptors, bind very tightly. So for shorter acting opioid like fentanyl or heroin comes into the brain, it does not easily get onto those receptors. So patients will often try by using something and they realize, oh, I don't feel this. So then they won't waste any more money on it. These are some of the medications that are used for alcohol treatment. Remember, a lot of your patients that you are prescribing opioids to are secretly drinking at home. Now, when I say they're secretly drinking, I don't mean that they're necessarily drinking alcoholically, but they might be drinking more than you think. And if you combine long-acting opioids with or without short-acting opioids, a muscle relaxant, a little bit of a benzodiazepine, you just throw like 2 margaritas into the mix, the person could just overdose right then and there. So it's important to educate our patients, and it's also important for us to remember that people will not always tell us what all they're doing at home. So these are some of the medications, both on-label and off-label, that are used for alcohol use disorder. And some of them overlap with, pain, like gabapentin. They overlap with post-acute withdrawal from opioids, and they overlap with maintenance treatment, like naltrexone. Okay, so now we're going to do a little bit of psychosocial interventions. Let me see how much time we have left. Not a whole lot, but psychosocial interventions are the backbone. They're the backbone of treatment, they're the backbone of recovery, whether somebody's on a maintenance agonist medication like methadone or buprenorphine or not. So when I teach medical students or residents, they kind of fall into 2 groups, 50-50. 50% of them are obsessed with the neurobiology. They all want to discuss is the detoxification period and the pharmacotherapy, because that's their comfort zone. Even psychiatry residents, some of them who are very biological. Ours tend to be more holistic because that's how we select them. But then there's another set of doctors from any specialty who are very, very interested in sort of the global picture, the holistic picture, the sort of psychosocial combined with pharmacotherapy, the human story. So they kind of just divide up. One group isn't better than the other. They just have different comfort zones. And it's important to remember, though, that once you've detoxified somebody, once you've helped them get off their opioids, whether they were clearly abusing them or they were misusing them, or you feel that they're no longer beneficial and the patient's pain is not getting better with them, so why continue, or they have hyperalgesia. Remember, you have to refer them for some kind of psychosocial intervention. So for people that you're not very clear that they have an opioid use disorder, you can just refer them to like once a week therapy or bi-weekly, twice a month, with somebody who's knowledgeable about pain or addictions. But for people who have full-fledged opioid use disorder, they need serious psychosocial interventions. So always make a referral to a therapist or a counselor for this group of patients, specializing in substance use disorders and hopefully dual diagnosis, but at least substance use disorders. Now we're really talking about people who have chronic pain and opioid use disorder. And this person may not have a PhD. So let's say you have a PhD psychologist who's incredibly knowledgeable about, all psychiatric issues, psychology, but doesn't know anything about substance use disorders. They're not the best therapist for your patient. You might send them to somebody who's an LADC, licensed alcohol and drug counselor, that has an associate's degree, but knows a lot about substance use disorders, dual diagnosis, and that might, help them with getting better from this condition. If they really need structure where they need to be taken away from everything to focus on how to get better from their substance use disorder, need to be soaked in the treatment where they're doing it, 24, not 24/7, but 8 hours a day for weeks at a time, they need to go away to a residential program. Because for them to use from a residential program, they'd have to actually make the decision to leave and go somewhere and get some drugs, which is several steps. These are not locked door programs unless they have a probation officer. Even then, they can go away and choose prison. So they have to be willing to go there, and they have to be willing to give up everything else: alcohol, benzodiazepines, amphetamines, whatever prescribed, not prescribed. There's also intensive outpatient programs. We have a wonderful one at UConn that's kind of well-kept secret, where we have a dual diagnosis track and a psychiatric track. So the dual diagnosis track is 3 hours, 3 days a week, very doable. In the pandemic, it's entirely virtual. Everything else, we're seeing patients live when necessary, but our IOP is still virtual because we don't have the space to put people like 6 feet apart. And patients have really done well in the pandemic in our IOP, virtual IOP. I know because I see some of them referred to me afterwards in the addiction clinics. Then, does the patient need a referral for detoxification? Are they going to be able to detox at home, or are they just going to drink a lot? So maybe they need to go inpatient. Remember, your patient on opioid pain medications may need to be hospitalized to detox them off of alcohol. So there's like this complex thing. And then you need to work with your patient to have a release of information so you can communicate with the other people treating them. So these are some of the levels of care that we talked about. Outpatient clinics. Outpatient clinics are not the first place patients go to if they have a substance use disorder. They usually go through detox, intensive outpatient, or residential, or sometimes they go to long-term treatment. I've had patients that have gone away for 6 months, 2 years. The 6 months, 2 year programs they go to after the 30-day program, and they usually work from there, go to 12-step meetings, a variety of things. Sorry, I was just looking at the time. So on the left-hand side, I've put down some of the evidence-based therapies that are used when your patient goes away to see a professional that specializes in substance use disorders. So once they're in that world of addiction recovery, they get some of these treatments. Relapse prevention therapy is basically cognitive behavioral therapy for substance use disorders. You have 12-step facilitation. You have a ton of family involvement. The only way you don't have that is if the patient refuses to sign a release of information. You have motivational enhancement therapy, which you can do in the office, which is a whole another talk. And just to tell you guys that contingency contracting, exchanging clean urine drug screens for vouchers that can be redeemed for goods and services, such as going to a department store and buying some nice clothes, buying, Christmas presents for your children, going out to eat. Contingency contracting has been researched since the 1990s when I was a fellow, an addiction psychiatry fellow, and they have produced the best results out of all treatments for drug use, not for alcohol use disorder, but for other kinds of drug use disorders. This voucher exchange for clean drug screens has produced the best results. From the 90s, we are now in 2021. They're not used anywhere except at the VAs, contingency contracting. Why is that? Well, if you ask me as an addiction psychiatrist, it's societal and political stigma. Because can you imagine the headlines, addicts paid to stay sober? But really, science shows it works, and it's not because you're just buying sobriety. It's because of the mesolimbic pathway. You go back to that lizard brain, and when the patient gets these vouchers, they can do things that they haven't done in years. Maybe they can go out, take their family out to eat. They can maybe buy a nice winter coat that's new, and they learn to enjoy those smaller, slower rewards, and slowly their brain changes. So it's kind of a retraining of the brain. Sometimes in these studies, they've linked two patients together, and if one patient has a positive drug screen, then both of them don't get the vouchers. And those are very successful too, because they kind of have peer pressure. Then on the other side, you have a lot of wonderful 12-step groups, Alcoholics Anonymous, Narcotics Anonymous. These have open meetings where anybody can go that doesn't have a substance use disorder. I would highly recommend you go to one because they're incredibly inspirational, and you'll see. I mean, the first time I went to a 12-step meeting, I went to an NA meeting. And honestly, for a minute, I wanted to have a heroin addiction so I could come back. But then I quickly was replaced by the thought that, no, this would not be good for my life. Why would I develop a chronic disease? So, but they are very inspirational. Patients will tell you, oh, they're very religious. Well, if you go to California, then the, AA meetings will not even mention God. They'll probably just say higher power. If you go to Atlanta, where I lived for a few years, then they're saying Jesus. So it just depends. But the patient does not have to be religious to participate in AA. There's Women for Sobriety. For some of my patients go to it and they really like it. Refuge Recovery and Dharma Recovery, which are based on Eastern principles, sort of Buddhist, Hindu principles, they're very gentle, and some of my patients go to those and they really like it. Smart Recovery, I don't have any patient going to Smart Recovery right now. I don't even know how many meetings they have, but they're kind of like a support group that takes all the spirituality out of the treatment. But the rest of addiction treatment, spirituality is an arm. It's the only specialty in medicine where spirituality is actually on the treatment plan as one of the arms, along with medications and very specific concrete psychosocial treatments. Not religion, just a way for the patient to kind of come out of themselves and realize that while they have a disease, the decision to stop, however difficult it is on them, and that they cannot live this self-centered life while they're living on the planet. That's the main thing, basically. So if, we went over this, why you would refer out. So, if your patient's really not getting better, maybe you started them on naltrexone, buprenorphine, you referred them to a counselor, but now they're really struggling, then maybe they need more structure. They need like IOP, or they need to go away somewhere, or maybe you refer them out to a methadone maintenance program. So, you have to kind of, it's a kind of gray zone organic process also, and you might have to do some motivational enhancement to get them there. So I won't go into the psychosocial treatments. I'm going to stop and take questions, but just for people who wonder what happens in these groups. So it's very here and now. It's very learning based. It's a mix of very esoteric, intangible things like 12-step philosophy, combined with very concrete, repetitive things. So one example, which is very applicable for us as healthcare professionals, is HALT. Hungry, angry, lonely, tired. So let's say you're in the hospital, things are happening. It's now 7 o'clock. You are somehow stuck there, and you can't go home because you have patients to see and work to do. You're now hungry. You're kind of irritable and angry. You're exhausted. You're lonely. For a patient with substance use disorder, they are going to just take all these feelings, or any one of them, and use something. It could be your prescribed opioid. So this cognitive behavioral therapy makes them sit down, write down all these things, and learn techniques on how to do other things. Eat a sandwich, take a break, sit with your feelings. If nothing gets better, if they're able to, then take a nap, obviously, And they learn techniques to cope with these cravings and triggers. They learn like how to avoid people, places, and things. A lot of times patients will say, I've been through this treatment so many times, I could teach these classes, but it's not intellect that makes people get sober. Otherwise, impaired physicians, impaired pharmacists and nurses would be the first to get clean. They do have a very high recovery rate, but that's because they do a lot more treatment than the average person. So I'm going to stop here because the rest of it, a lot of it is psychosocial treatments, the details of it, which we don't have to get into. This is just a spiral model of change. Prochaska and Di Clemente were these scientists, they were psychologists who studied how people change behaviors, particularly addictive behaviors. So they said they have to go through all these stages, even if they appear to change overnight. And without intervention, it takes an average of 7 to 9 years for human beings to change behavior. So I am going to stop here, not get into expert, and take questions. That was a lot of information, guys. I hope you liked it. We'll wait 2 more minutes. If you don't have questions, maybe I'll do expert. Okay, why don't I share the expert slides then for like 5 minutes? Okay, SBIRT is screening, brief intervention, and referral to treatment. It's been around for a long time. I would say at least 10 years. And it's much favored by the federal government, including SAMHSA, Substance Abuse and Mental Health Administration, which is the federal government's huge body to organization that does, treatment, education about substance use disorders. It's exactly what it says: screening, brief intervention, referral to treatment. So it's a public health approach to deliver early intervention and treatment. Now, you don't have to, SBIRT is not only for people who have a substance use disorder, it's for people who are at risk. So there may be somebody who's just entering that gray zone we talked about, where they are in your office for pain management, and you're starting to see some early behaviors that tell you that they are at risk of developing a substance use disorder. So this, you can do the screening, brief intervention, and treatment, and patients have already developed these disorders. And there are 2 basic models. The medical model is more favored by physicians who specialize in addictions, whether it's addiction psychiatry, addiction medicine. It's more of a directive model where we do a lot of psychoeducation and kind of tell people, recently I saw a patient in the office who's actually 6 months clean and was on the liver transplant list, but has gotten off, thank God. And she went through our intensive outpatient program. So, with her, it's not expert, but, this is treatment, but I did education about the risks involved in her organs and her liver. Now, if I'd seen her, in a general psychiatry office or the emergency room, I might have done the same thing. But the medical model is very directive. It's very, packed with information. Then a lot of psychologists and other people who are coming more from a liberal arts background, they use the motivational interviewing model. It's very much favored by psychologists. It's also excellent where it's like you go with the resistance and you kind of meet the patient exactly where they're at and just kind of talk to them and slowly move them forward. Expert can be done in like 5-6 minutes. I've done it. So it's just you have to kind of dive into it and not linger. Sometimes we use a mix of these 2 things. And it can be delivered in hospital emergency rooms, primary care offices, clinic-based practices like FQHCs, or any community setting. It really takes like 5 to 7 minutes. And these are some of the screening instruments for substance use disorder that sometimes accompany SBIRT. You ask the patient, can we do a screening instrument? So the screening instrument, if they test positive, it doesn't mean that they have a substance use disorder. So if they test positive for the cage or the must, it doesn't mean that they have alcoholism. It just means they're at risk of developing some alcohol use disorder. But remember what I said before, a lot of these screening instruments, like the DAST, drug abuse screening test, these or MAST AID, short Michigan alcoholism screening test adapted to include drugs, they often don't pick up that patient that's getting everything from the same prescriber and then throwing in the alcohol at home. So these are our acknowledgements. We are very grateful to the Connecticut Department of Public Health, which is the grant funding for our program. Okay, so I will stop again. Any questions now? We do have 5 minutes. Okay, well, if there are no questions, we will stop here and give you 4 minutes back of your life. I don't know what you could do with 4 minutes. I would eat a small snack, but if there was one at my desk. Thank you everyone for listening and for attending the program. Oh, thank you. Somebody's putting something into the chat. Okay, great. Thank you so much, Dario. Kelly, if anybody wants the slides, can we send it to them?
Yes, we'll be sharing the slides after the presentation. So thank you everyone for joining us today, and we will send a follow-up email. All right, thank you.